Raed Awaisheh. He is well-known interventional cardiologist. He will talk about ReThink heart failure with Dapagliflozin. Dr. Raed.
Thank you very much, Dr. Osama, for your it's late today, and still we have people keen to hear from us. Thank you very much for staying. My mission today is, or from this coming half an hour actually, to talk about the DABA and its effect. And it's a broad effect actually. And it's very important actually to go now in the disclaimer of the company that this medication is right now in Jordan is used for the treatment of patients with type 2 diabetes, patients with chronic heart failure with regardless to the ejection fraction, and for the treatment of chronic kidney disease. So this we celebrate of having medication to cover all of these things that we were not covered in the past. And if I'm going to divide my talk, I will start by talking about the burden and the unmet need in heart failure and what Deliver would like to deliver for heart failure patients, and the famous DABA, heart failure with Deliver, pooled analysis, and then we go to the guidelines and summary. When we come to the burden and the unmet needs for patients with heart failure, I want you to imagine the heart failure as a monster, and this monster is really big, that it is affecting 64 million people worldwide, and it's really big that it can cause heart failure in the first cause of admission for patients with heart failure to all patients with more than 65 age. And the mortality actually, it is more deadly. This monster is really a killer that kills even more than most of the cancers in men and women. Over the 5 years, the survival is less than 50%. And this monster is growing up significantly, that it is not calming down. The hospitalization is increasing, and the mortality after each attack is increasing. And another feature of this monster, so you will know how to deal with it, that despite that it is big and growing, it has the way to hide itself very well. So the patients, they can have symptoms with heart failure for 5 years, 40% of them before presentation and diagnosis, and 75% of the patients actually their first diagnosis happen with first admission, unplanned admission, or visit to the emergency room. And we are not treating heart failure very well, so we are not defeating ourselves from this monster very well, because the medications that we are giving are suboptimal. And once the patient has an attack, once the patient has an attack of heart failure, 30% mortality in 1 year is expected. Another feature that it is developing itself, this monster is developing itself. In a way, it is not only for the reduced ejection fraction, it is for preserved ejection fraction. So this is how it masks itself, difficult to diagnose, but it is there. So the heart failure with the preserved ejection fraction, it is more in elderly, more in women. As you can see here in the green line, the women and the elderly, you can see that how much it's increasing in preserved ejection fraction, while in reduced ejection fraction, you can see that the men, they have more prevalence, and it is not increasing that much with age as the preserved ejection fraction. And really, it is still involving good number of patients. The preserved ejection fraction happens in 1 to 2% of the population. And it is now increasing even more than reduced ejection fraction. To have patients with heart failure with the preserved ejection fraction are more than 50. It is 50% now, and it is growing up. And they have more morbidity, more diabetes, more hypertension, anemia, chronic renal failure. And when we come to treat patients with heart failure with preserved ejection fraction, it is really difficult, which makes it really the single largest unmet need in cardiovascular medicine. So in cardiovascular medicine, preserved ejection fraction heart failure is really the big monster. Okay, and not only this monster can come in different ways, heterogeneity. It can do the, what we call it, camouflage or something like this, that even for the international classification for diseases, they're having difficulty actually of diagnosing patients with preserved ejection fraction, and more than 50% are missed because of the lack of the information. And the patients with preserved ejection fraction, actually, they need more investigation to have the diagnosis with heart failure. That makes us concluding the following, that the patients with the preserved ejection fraction present with the comorbidities, different comorbidities, and they need more investigations actually to find them. Pro-BNP is very helpful, and the cutoff may be 125, like 99 grams per liter, and it is easier for reserved ejection fraction actually to diagnose. When we have ejection fraction below 40, this is easy to find out, while preserved ejection fraction is difficult. That's why the European guidelines, or the ESC, they have developed this diagram to make the diagnosis of preserved ejection fraction heart failure easier by getting the patient with shortness of breath and to find out he has heart failure or not. By doing these simple investigations at the beginning, with doing the ECG and the X-ray and the echocardiogram, and then we find out if the patient has high risk for preserved ejection fraction, or intermediate, or low risk. Low risk, maybe it is very important to rule out another cause, while if you have high likelihood of having preserved ejection fraction heart failure, you go and try to find out the underlying cause, and you should do the investigations to find out the underlying cause. If you have it with an intermediate probability, you go with further diagnostic tests, like invasive or non-invasive, by doing echo, dobutamine echo, or cardiac cath, and to do the hemodynamics and find out if the patient has heart failure with a preserved ejection fraction, and then we go from there. Before going to what should deliver for patients with heart failure, let me remind you about the Dapagliflozin and its importance as one of the landmark studies to treat patients with reduced ejection fraction. Dapagliflozin, as you know, is a study of patients of around 4,700 patients, ejection fraction below 40%. They have high pro-BNP, and the GFR is more than 30. The average ejection fraction actually is 31. 55% of them, they don't have diabetes, and the average GFR of below, you have 40% of them, 41% actually, below 60 mil per minute GFR. And the primary or composite endpoint, as the surrogate endpoint actually, it is the cardiovascular death and worsening of heart failure, or admission with heart failure, or visiting the emergency room with heart failure, and another secondary endpoints. This is the famous Dapagliflozin that you know. And by Dapagliflozin, you know that patients with reduced ejection fraction, with the follow-up of 2 years, showed that there is significant reduction in the cardiovascular death and hospitalization or deterioration of heart failure by relative risk reduction of 26%, cardiovascular death by 18%, and worsening of heart failure reduction of 30%. And you can see that the early separation of the curve from the beginning in day 28, you can see the difference, which means that really the medication is really working well. And also for the number of patients that you need to treat to achieve the primary endpoint are 21 patients only you need to treat to achieve the primary endpoint. Also, the all-cause mortality reduced by giving DABA, and the all-cause mortality reduced by 17% relative risk reduction. Now we come to deliver for the other half of the patients or the other part of the patients where they have ejection fraction more than 40%. They have high incidence of comorbidity, and the result was good, actually, even in this group of patients with 18% relative risk reduction, and the effect is consistent over the different spectrum of ejection fraction with good safety. So when we come to the pooled effect of the DAPA-FF and deliver, you can see that there is a significant reduction in the cardiovascular death by 14%. So this is a summary of deliver again. 6,000 patients, ejection fraction more than 40%, 2 arms, DAPA-10 or placebo, and the follow-up visits of around 600 days, and the primary endpoint is cardiovascular death or deterioration of heart failure. The characters of the patients, the criteria of the patients, the most important thing that their ejection fraction is more than 40%, as we said. And when you look to the patients, you can see that their age is 72 and above the mean age, which means that really these patients are old, and with comorbidities, lots of comorbidities, and they separate them very well actually in the study that almost they have 3/3 of ejection fraction of 41 to 49, the second third 50 to 59, and the third more than 60%, and they have heart failure. So preserved ejection fraction, heart failure more than 60. And when you look to the patients, they are not naive patients, they have good medications, and they have high pro-BNP. And this is the importance of pro-BNP actually of diagnosing patients with heart failure with preserved ejection fraction. And when they divide them to the 2 arms, the Dapagliflozin 10 milligram once daily, or placebo, they separate patients in different, in two groups, very well distributed according to the age, gender, region, heart rate, vital signs, everything. And you look even for the diabetes, you can see that the patients of almost same criteria of DAPA-HF, where you have 50, there you have 55% non-diabetic patients, here almost the same. And they have lots of comorbidity, as we said, and they are divided into 3 groups according to the ejection fraction. And this good number of them, actually, they have atrial fibrillation. They are already in the medications. They are not naive patients. And the primary endpoint clearly seen here in this curve. You can see the patients that with DAPA, they have 18% relative risk reduction, lower in achieving the primary endpoint, and the number of patients that you need to treat is 32 patients. So when we come to the line, as you can see here, the line and the line here, which one in favor actually of DAPA, according to different spectrum of the patients with different criteria, with different ejection fraction, with different even GFR, you can see that all of them in favor of giving Dapagliflozin. So this medication can be given almost to every patient with different criteria. And the secondary endpoint actually achieved for the quality of life and the cardiovascular events. So for the safety, again, it is very safe medication, even when you start it very early during hospitalization or after discharging the patient. And it is similar between the group, same as the placebo. So it is very safe medication actually to be given and to be started early. Now when we come to the, when we come to the largest and broadest trial, actually, the delivery is the largest one, because actually the number of patients, 6,200 patients. And they are separated in the good way, as I told you, and the ejection fraction more than 40. The patients with the important point in this slide actually to look at this group of patients, that 18% of the patients, they were having low ejection fraction below 40, and after giving them DABA, they improved, and they have now recovering according to, or they have some recovery, and their ejection fraction now jumped more than 40%, and 18% actually of those patients, of the group of the patients collected, they were of this group that having reduced ejection fraction in the past. And in spite of all of this, that is, you still have a cumulative result of reducing the primary endpoint, the cardiovascular death and worsening heart failure by 18% relative risk reduction. And the secondary endpoint actually is achieved, and the and the mortality and the significant improvement of heart failure symptoms or significant reduction in total worsening of heart failure events and cardiovascular death were achieved, and in a very safe manner. So the SGLT2 inhibitor include DABA are recommended in patients with heart failure regardless of the ejection fraction in the treatment guidelines. And when we pooled all the patients with DABA HF and Deliver, and they are almost more than 11,000, 6,000 plus from Deliver, 4,000 plus from DABA HF, and we include all the patients with different ejection fraction, from reduced to mid-range to preserved ejection fraction. You can see that the result for the patients, even if they have ejection fraction below 40 or more 40, it is significant, and the primary endpoint is achieved along the ejection fraction. Here we are. Again, the purpose was to go with the pooled and to look at the outcome not only for the cardiovascular death, but all cause of death and total hospitalization, MACE, composite endpoint, and all of these things. And we need to have the accumulative result from the lowest ejection fraction we have and the highest ejection fraction, even above 60. You have still a marked improvement in the primary endpoint by 14% relative risk reduction. And all in favor of giving DABA, either for preserved or for reduced. And here, when we look to them separately, one by one, cardiovascular death reduced by 14%, all-cause mortality by 10%, total hospitalization by 29%, first heart failure hospitalized 26%, and cardiovascular death, MI or stroke, by 10%. This is the means. So the effect was constant across the full range of the ejection fraction, as you can see here below the line, and almost the line is straight from the lowest ejection fraction to the highest, from 15 ejection fraction to 75 ejection fraction. You still have the same effect, not same as the other medications, either from the same group, from the same class, the SGLT2, or the other medications that are known for us to treat heart failure, where you can see that the line is start to tilt up when you have a higher ejection fraction and lose of the effect of the medications when you have an ejection fraction 60 and above, while it is constant with DABA, even with higher ejection fraction. That's why the guidelines is going straightly there to recommend that the DABA is a class 1A recommendation as first-line medication for heart failure across the range of ejection fraction. And you should initiate it as soon as you can, and the rapid up titration of the dose, and we are luckily here that we have in DABA, it is a fixed dose, so even up titration is not needed. Very exceptionally, you need that. And the patient to be started on the DABA even before discharging him from the hospital, even if he get admitted with acute heart failure, is very safe and even showed a better result than delaying starting it later on. DABA is a class 1A in diabetes, in a chronic kidney disease also. So the guidelines for the management of patients with mid-range heart failure, almost it is the same. After you treat your patient from the over volume by giving some diuretics, which is class 1A, DABA is there as a class 1A, but the others, they are not. So the recommendation is very clear for SGLT2 as a class 1A. Preserved ejection fraction, again, diuretics, you need it only when the patient is overloaded. And after that, the class 1A is the recommendation for SGLT2 inhibitor in preserved ejection fraction patients. And so we have it for the reduced and for the mid-range, and also for the preserved ejection fraction that the SGLT2 is a class 1A. Starting it very early, it is 1B, even from inside the hospital. The patients with diabetes and chronic kidney disease, now SGLT2 is in the guidelines as 1A. When we come to the American guidelines of 2022, you can see that the Americans make them in stages. Stage A, where you have just risk for heart failure, there is no even symptoms of heart failure. And stage B, when you have pre-heart failure, where the patients are there. And when you have patients with heart failure with different ejection fraction, as you can see here, separated in the 3 groups. You can see that SGLT2-1 is indicated in stage A, in stage B, and in different classes of reduced mid-range or preserved ejection fraction. Again, for the ACC guidelines 2023, the patients with BEF, SGLT2 is recommended, and the other medications you may add them as if there is an indication. But the effect actually, which is with a strong evidence, comes from the SGLT2, which should be initiated as the first line, not any other medication before them. And the patient either to start them on this SGLT2, either from the hospital or in the clinic. So in summary, I have 8 minutes more. So in summary, SGLT2 inhibitor includes Dapagliflozin, benefit in patients with heart failure regardless of the ejection fraction, reduced mid-range or preserved ejection fraction, and the guideline-directed medical treatment, including SGLT2 inhibitor, is suboptimal. This is the situation right now. And I think in our study in Jordan for heart failure, really we are suboptimal. Deliver and DABA together showed that the Dapagliflozin across the range of ejection fraction is really effective. And the pooled analysis demonstrated constant effect across the ejection fraction with reducing a surrogate endpoint, which is the cardiovascular death, and the relative risk reduction of 14%. DABA is the only SGLT2 inhibitor. It is the only SGLT2 inhibitor with a clinical, meaningful mortality benefit in patients with heart failure. The other SGLT2, they did not prove it yet. They improve in the mortality. And DABA is the key component of medical treatment in patients with heart failure, regardless of the ejection fraction. Thank you.
We'll keep the question to the end of the session. Do you take a couple of questions? Okay.
I saved 6 minutes.
Thank you, Dr. Raed, for your nice presentation. I would like to add some information, new information about the Dapagliflozin or SGLT2 inhibitor in the management of heart failure. As we know, heart failure is associated with hyponatremia, which is a bad prognostic factor in LV dysfunction. It has been found recently that the use of SGLT2 will lower the excretion of sodium in the urine, and it will prevent this bad effect. However, the mechanism is not actually clear, but I think it is a hopeful treatment for to protect the patient from the effect of hyponatremia, which is a very bad risk factor in heart failure. So it is a hopeful treatment. Hyponatremia is dapagliflozin is a new treatment for hyponatremia and heart failure. Thank you very much.
Hyponatremia?
New researches and the trials issued that dapagliflozin or SGL2 will decrease the urine excretion, sodium excretion in the urine, hyponatremia. So it has some cardiovascular protection and even renal protection.
Yeah, actually, this is the mechanism of action of the sodium glucose GLT2 inhibitor. So it works in the receptor. So this is how it works. Yeah.
Any more questions?
Oh, yes. Thanks, Raed. I hope I didn't miss your take-home messages regarding surgery in patients who are taking DAPA. What are the recommendations currently for a patient who's going for non-cardiac or cardiac surgery or even a cath?
Yes. What we know, or really the most significant side effect, if we say side effect or adverse event happens with patients with SGLT2 in general, is the euglycemic ketoacidosis, which happen in a patient who go for surgery or go in fasting, long fasting, and avoiding fluids. So the recommendation, I agree with you. Actually, this is what we do, is we stop SGLT2 2 days before the surgery, and we resume it after surgery by 1 day. So I stop it for 3 days. This I remember in the practice. I don't have the evidence now. If you remember it, Raed, I think you are there.
I think, if I'm not mistaken, that some of the recommendations up to 5 days. And I was surprised to read that. But apparently this is getting very serious now, which is before cath in particular, especially if the dye was too much.
Yes.
So I'm not sure about our colleagues, the panelists, what's their practice, but I start stopping it 5 days ahead of my procedures.
Oh, even before cath?
5 days. Yeah.
In my practice, what I do actually is not for cath. I don't stop it because the patient is awake and eating and drinking, and I'm not afraid of this. I think we need more evidence. Maybe if anybody has any information.
Right. I don't think to be stopped in the coronary angiography or PCI, but in major surgery, yes, you can stop it 4 to 5 days before the surgery. And even if the patient is on insulin, don't start to decrease the dose of insulin. That's why it will increase the DKA in these patients. With good hydrations and avoid to decrease the dose of insulin, it will not lead to DKA. Raed, thank you for this informative informations. All of us know that SGLT2 inhibitor now one of the pillar in heart failure with reduced, mid-range, and preserved. Can you tell us, what do you think the proper mechanism for SGLT2 inhibitor, especially in heart failure with preserved ejection fraction?
Actually, the SGLT2 showed the improvement in heart failure, even for reduced ejection fraction by incidence. It was started for diabetes, and then we find that it is good for heart failure. And the main mechanism is through the sodium channel, sodium glucose channel in the kidneys. I don't know more than this at the moment. For preserved ejection fraction, it is the same. I think it is reducing the preload and changing the sodium metabolism in the body and the excretion of the sodium and the glucose and changing the balance.
Do you think the anti-inflammatory and the anti-inflammatory process in this molecule, especially in heart failure with preserved ejection fraction, play a big role in heart failure with preserved ejection fraction or not?
I think all the anti-inflammatory or pleiotropic effect, we say it for many medications in the past, as the statin and the other medications. I don't believe that the SGLT2 have any of these criteria. I'm not sure if somebody has.
Last question, Dr. Ayman.
I just
Ayman,
have a
Ayman.
comment. I mean, the mechanism of SGLT2 inhibitors are like enormous. I mean, they work by reducing, they are diuretics, but they have the diuresis, like tissue diuresis, more than vascular diuresis. They reduce the body weight, they reduce the blood pressure, they reduce the fibrosis, they have mechanism affecting the, you know, the potassium channels. So they have multi-effect. I mean, as far as I know, patients who undergo anesthesia are the ones you have to be really careful. And, you know, stopping it for 5 days might be really excessive. I mean, I've been reading that there is a tendency for the Dapagliflozin to be more effective in diabetic patients in terms of body weight reduction, blood pressure, and cholesterol, while DABA has a tendency to be more effective in non-diabetic. Do you have any?
DABA is more effective in non-diabetic, and
Right,
IMBA
and
is
there's a
more
tendency
effective in
for,
diabetic.
yeah, like
What I know regarding this matter actually that we have 2 doses for IMBA, the 10 milligram and the 25 milligram. 25 is recommended for patients with diabetes and patients with heart failure without diabetes to go for 10 milligram. This is the only information I have.
Okay, thank you, Dr. Raed.
Thank you, Dr. Sam. Thank you, Jamil.
Our present. Present, Dr. Speaker.
The next presentation will be by Dr. Zaher Kasih, Kasih from Jordan, Amman. He will talk about update in the management of heart failure. Yes, please, Dr. Zaher.
Mr. Chairman, panel members, ladies and gentlemen, I would like to thank you for attending this presentation. I would like to thank Boehringer Ingelheim for asking me to give this presentation. I'll be talking about an update in the management of heart failure. Now, the universal definition of hypertension is the presence of symptoms and signs of hypertension caused by a structural and/or functional cardiac abnormality and corroborated by at least one of the following, that is elevated natriuretic peptide levels and objective evidence of cardiogenic pulmonary or systemic congestion. Common symptoms and signs that patients may present with include breathlessness, orthopnea, or bendopnea. Bendopnea is dyspnea on bending over, paroxysmal nocturnal dyspnea, reduced exercise tolerability and inability to exercise, fatigue, tiredness, peripheral edema, and swelling of parts of the body other than the ankles. This is in addition to evidence from diagnostic tests, including abnormal findings on the EKG, as well as an NT-proBNP more than or equal to 225 picogram per milliliter, or BNP at least 35 or more picogram per milliliter, in addition to chest X-ray findings. Now, guideline-directed medical therapy differs across the classifications of heart failure based on the ejection fraction. Heart failure with reduced ejection fraction is defined an ejection fraction less than or equal to 40%. Heart failure with mildly reduced ejection fraction is with an EF between 41 and 49%, and heart failure with preserved ejection fraction is with an EF more than 50%. Now, heart failure with an improved ejection fraction is whenever there is an increase in 10 points from less than 14 to over 40 in the ejection fraction. The proportion of hospitalized patients with heart failure with preserved ejection fraction, HFpEF, have increased over the time. It accounts for around 50% of the patients with heart failure, around 35% of the patients, they have an EF less than 40%, and around 15% of the patients, they had an EF between 40 and 50%. Heart failure is a huge burden. Around 1 in 5 people would develop heart failure. It is the #1 cause of hospitalization in people over 65 years of age, and around 30% of those admitted to hospital are readmitted within 90 days. And around 30% of the patients would die within 1 year of hospitalization for heart failure, and around 50% of the patients would die within 5 years. So in addition to cardiovascular outcomes, heart failure significantly reduces quality of life and causes a high symptom burden on a daily basis. 76% of the patients find it difficult to carry out usual activities. 66% they have mobility problems. 68% of the patients they report some kind of pain and discomfort, and 50% of the patients they have anxiety or depression. 24% of the patients they struggle to take care of themselves. So improving heart failure symptoms and quality of life continues to be an unmet medical need in patients with heart failure. Worsening renal function and hyperkalemia and hypotension are key reasons for deviation from guideline-directed medical therapy. Reasons documented for discharge with congestion include renal dysfunction in 27% of the cases, and reasons documented for discharge with no or less ACE inhibitors or ARB therapy include hypotension in 41% of the patients and worsening kidney function and hyperkalemia in around 31% of the patients. Now, the treatment goals for patients with heart failure include improving survival, preventing hospitalization for heart failure, preventing and relieving symptoms, improving quality of life, and increasing functional capacity. There remains an urgency to improve outcomes for patients with heart failure. There is still a high unmet need in heart failure. Despite established treatment options, hospitalization and mortality due to heart failure are still unacceptably high. 50% again of patients with heart failure, they die within 5 years. Dapagliflozin Jardiance has demonstrated improved glucose control in people with type 2 diabetes as well as cardiovascular and kidney benefits in people with chronic kidney disease and or heart failure independent of type 2 diabetes. So there are benefits in the metabolic benefits in people with type 2 diabetes out of phase 3 trials, improvement in cardiovascular and kidney function in patients with type 2 diabetes and cardiovascular disease out of the EMPA-REG outcome. And out of EMPEROR, there was cardiovascular benefits in people with heart failure independent of type 2 diabetes at baseline. And out of EMPA-KIDNEY, cardiovascular and kidney benefits occurred in patients with chronic kidney disease independent of type 2 diabetes at baseline. Dapagliflozin Jardiance provides triple protection by reducing risk for a broad range of your patients with those with both type 2 diabetes and cardiovascular disease. You get 38% relative risk reduction in cardiovascular death, 32% relative risk reduction in all-cause mortality. In those with heart failure, there's a 25% reduction in relative risk in patients with heart failure with reduced ejection fraction, reduction in cardiovascular death or hospitalization for heart failure. And in those with HFpEF, there is a 21% relative risk reduction in cardiovascular death or hospitalization for heart failure in those with an ejection fraction over 40%. And in those with chronic kidney disease, there is a 28% relative risk reduction in kidney disease progression or cardiovascular death. It used to be feared to start SGLT2 inhibitors in patients with chronic disease. Nowadays, it is definitely indicated in patients with chronic kidney disease in order to prevent progression of chronic kidney disease and also cardiovascular death. Now, looking at the story of SGLT2 inhibition in heart failure and looking at patients from normal ventricular function to preclinical condition to clinical stages of the disease and to detectable cardiac involvement, ending up with end-stage heart failure, you have multiple trials looking at heart failure prevention and also trials looking at heart failure treatment. Until 2021, all trials in HFpEF have failed to meet their primary endpoints, and this include the CHARM Preserve, iPreserve, PEP-CHF, TOPCAT, Paragon HF, and DIG ancillary. Now, starting with 2021, Emperor preserved involving a comparison between empagliflozin and placebo, with a primary endpoint of reduction of hospitalization for heart failure and cardiovascular death. It was in favor of empagliflozin, as well as the DELIVER 2022 dapagliflozin versus placebo, looking at hospitalization for heart failure, urgent visit for heart failure, and cardiovascular death. Again, it was in favor of SGLT2 inhibitor, DAPA. Now, empagliflozin was the first drug to show clinical benefits across the entire range of ejection fractions from patients below 40%. This is the Emperor reduced, with a reduction of cardiovascular death or hospitalization for heart failure, relative risk reduction of 25%, absolute risk reduction of 5.2%, and the number needed to treat only 19 patients. And then in the Emperor Preserve, looking at patients with heart failure with mildly reduced ejection fraction and those with preserved ejection fraction, again, there was a relative risk reduction of 21%, absolute risk reduction of 3.3%, and number needed to treat of 31 patients. There were two phase 3 trials investigating the efficacy and safety of empagliflozin as compared to placebo on top of the standard of care in heart failure across the left ventricular ejection fraction spectrum. Those patients with the HFrEF and those patients with the HFpEF, the same criterion, the same study population, patients aged at least 18 years with a chronic CHF with an NYHA class between 2 to 4. In the Emperor reduced, the EF had to be less than 40% with an estimated GFR of more than or equal to 20 milliliter per minute per 1.73%, and the same thing applied to the Emperor Preserved, but they had an ejection fraction more than 40%, and there were true HFpEF patients, not improved ejection fraction, and the patients were given either 10 milligram IMPA plus the standard of care or placebo plus the standard of care. The secondary endpoints were the first and recurrent HHF events and the slope of change in estimated GFR from the baseline. Again, Jardiance empagliflozin provided protection for people with heart failure across the LVEF spectrum by reducing the risk of cardiovascular death or hospitalization for heart failure. In the Emperor reduced, there was a 25% relative risk reduction in cardiovascular death or hospitalization for heart failure. And in the Emperor Preserved, in patients with HFpEF, there was a 21% relative risk reduction in cardiovascular death or hospitalization for heart failure. The efficacy was consistent across the subgroups, including patients with or without type 2 diabetes and patients with or without chronic kidney disease. Now, both Emperor Reduced and Emperor Preserved showed that empagliflozin significantly lowered the rates of cardiovascular death or first hospitalization for heart failure. There was an early and sustained risk reduction in cardiovascular death or hospitalization for heart failure, starting by the 12th day in patients with heart failure and reduced ejection fraction, and the 18th day in patients with heart failure and preserved ejection fraction. Empagliflozin protected the kidney by slowing the decline in renal function in patients with heart failure. There was a 2 to 4 times slower decline in kidney function with empagliflozin as compared to placebo, both in Emperor Reduced and also in Emperor Preserved trials. So this is, again, the use of empagliflozin is definitely in favor of the kidney. It's not against the kidney. And in looking at patients with the Emperor Reduced, empagliflozin consistently reduced cardiovascular death or HHF across a broad range of patients with HFrEF, including males, females, diabetic, non-diabetic, any class of NYHA, more than or equal to or less than 60 GFR, and whether they were on MRA or they were not on MRA, whether they were on ARNI or they were not on ARNI, it was always in favor of empagliflozin. Again, it was in favor of empagliflozin in the Emperor Preserved, and this is the first study to demonstrate a consistent clinically meaningful reduction in CV death or HHF in all pre-specified groups in heart failure, patients with an EF more than 40%, whether they were on ACE inhibitors, ARB or ARNI, whether they were on MRA or not, whether the NT-proBNP was less than or more than median, whether the BMI was more than or equal to 30 or less than 13, and at any level of systolic blood pressure, whether they were on having AF or they were not having AF, it was always in favor of empagliflozin. And again, Emperor preserved, again, it was in favor of empagliflozin, whether the patient was diabetic or non-diabetic, at any GFR more than or less than 60, at any NYHA, and whether they had or not had previous heart failure hospitalization. Now, empagliflozin Jardian has a proven safety profile in the treatment of patients with heart failure. You have to look for the side effects, which tend to be minimal, including sometimes volume depletion, sometimes symptomatic hypertension, occasional UTI, especially in females, especially in uncircumscribed men, and genital infections, and those who were not circumcised, and also occasional hypoglycemia and rare ketoacidosis, both in the emperor preserved and the emperor reduced. And looking now at the hospital setting, the question is that can we initiate empagliflozin in patients with decompensated heart failure after being stabilized? Now, the early benefits, again, with empagliflozin were observed in both the emperor reduced and emperor preserved. Again, as I said earlier, the statistical significance was reached 12 days only after randomization in the emperor reduced and was sustained from day 34. And in the emperor preserved, statistical significance was reached 18 days after randomization and was sustained for the duration of the follow-up period. Now, looking at the IMPULSE study, it studied the effect of empagliflozin in patients hospitalized for acute heart failure after being stabilized after the incident of acute heart failure. They received either EMPA 10 milligram or placebo. They were after that followed up. The composite primary endpoint was all-cause death, number of heart failure events, time to first heart failure event, and the change in quality of life. Now, out of the IMPULSE, there was an overall clinical benefit. There was a 36% more likely benefit with empagliflozin as compared to placebo. So empagliflozin was the winner concerning time to death, heart failure event frequency, time to heart failure event, and the quality of life. Now, the clinical benefits of empagliflozin were consistent across all pre-specified groups, whether they had de novo heart failure or they had a decompensated chronic heart failure. So the clinical benefits were consistent regardless of whether patients presented with de novo or decompensated chronic heart failure. Guidelines recommended the use of SGLT2 inhibitors, that is Jardian's empagliflozin, across the cardiovascular, renal, and metabolic spectrum. They were now included in the guidelines in the 2021 ESC guidelines in patients with HFrEF, in the Canadian guidelines 2021, in the American 2022 guidelines. ESC recommended SGLT2 inhibitors in 2021 as first-line therapy in HFrEF patients, and SGLT2 inhibitors are recommended as foundational therapy for patients with heart failure. Now, in patients with HFpEF, the 2022 American guidelines, they say that SGLT2 inhibitors have the strongest recommendation, class 1A, within available therapies for both heart failure with mildly reduced ejection fraction and those with heart failure and preserved ejection fraction. Now, what are the 2021 ESC guidelines recommendations in HFrEF, and what are those in 2023 guidelines? The 2021, the key changes to HFrEF treatment in the 2021 ESC guidelines. There is a new classical recommendation therapy for HFrEF, that is the SGLT2 inhibitors. Dapagliflozin and empagliflozin are now included in the class 1 therapy for HFrEF, and the 4 key drug therapies, that is SGLT2 inhibitors, ACE or ARNI, MRA, and beta blockers, they should be initiated as quickly and safely as possible, and there is the importance of tailored management in these patients. So drugs that are recommended in all patients with HFrEF, they received 1A class, so it is the highest recommendation of any drug. It included ACE inhibitors, beta blockers, MRA, and now for the first time, Dapagliflozin and empagliflozin are recommended for patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. It is a class 1B recommendation for sacubitril valsartan, ARNI, as a replacement for an ACE inhibitor in patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. Now, the recommendation for heart failure with mildly reduced ejection fraction and HFpEF patients, it is a class 1C recommendation to screen for and treat etiologies and cardiovascular and non-cardiovascular comorbidities is recommended in patients with HFpEF, in addition to diuretics being recommended in congested patients with HFpEF in order to alleviate symptoms. And in those with the mildly reduced ejection fraction, it is again a class 1C recommendation for diuretics, while it is a class 2B/C level of evidence for ACE inhibitors, ARBs, beta blockers, MRA, and ARNI. Now, what are the new 2023 update for the diagnosis and treatment of acute and chronic heart failure, the ESC guidelines? Now, the recommendation is in patients with symptomatic heart failure and mildly reduced ejection fraction, the HFpEF patients and the mildly reduced ejection fraction. In the mildly reduced ejection fraction, an SGLT2 inhibitor, DAPA or EMPA, is recommended in patients with mildly reduced ejection fraction to reduce the risk of heart failure, hospitalization, or cardiovascular death. And in those patients, symptomatic patients with preserved ejection fraction, the same thing applies, and SGLT2 DAPA or EMPA is recommended to reduce the risk of heart failure, hospitalization, or cardiovascular death. Now, what are the 2023 ESC guidelines for the management of cardiovascular disease in patients with diabetes now? The guidelines are, it is a 1A recommendation for SGLT2 inhibitors, including DAPA, EMPA, or sotagliflozin, recommended in all patients with HFrEF plus diabetes mellitus, type 2 diabetes, in order to reduce the risk of heart failure, hospitalization, and death. And again, it's a class 1A for sacubitril valsartan or an ACE inhibitor, again for beta blocker and MRA. Now, for patients with an ejection fraction of more than 40% plus diabetes, again, empagliflozin or dapagliflozin only are recommended in patients with type 2 diabetes and an EF more than 40%. That is the HFpEF and the mildly reduced ejection fraction to reduce the risk of heart failure, hospitalization, or cardiovascular death. Again, it's a 1A recommendation for diuretics to be used in patients with HFpEF or MR and plus diabetes with signs or symptoms of fluid congestion in order to improve symptoms, exercise capacity, and heart failure hospitalization. Now, again, the guidelines in the measurement of cardiovascular death in type 2 diabetes, SGLT2 inhibitors are recommended in type 2 diabetes patients plus multiple ASCVD risk factors. They don't have to have an established cardiovascular disease. It is a 1A indication for diabetic patients with multiple ASCVD risk factors or established ASCVD in order to reduce the risk of heart failure hospitalization. And again, the DAPA, EMPA, or SOTA are recommended in patients with type 2 diabetes and HFrEF in order to reduce the risk of hospitalization and cardiovascular death. Now, you shouldn't use pioglitazone because it is associated with an increased risk of incident heart failure in patients with diabetes and is not recommended for glucose-lowering treatment in patients with at risk of heart failure or previous heart failure. You shouldn't use the DPP-4 saxagliptin because it is associated with an increased risk of heart failure hospitalization in patients with diabetes and is not recommended for glucose-lowering in patients at risk of heart failure or with previous heart failure. while it's a class 2A recommendation for sitagliptin and linagliptin to be used, and it's a class 2A level of evidence B for metformin. Now, the last thing I'm going to talk about is the prevention of heart failure in patients with chronic kidney disease and type 2 diabetes. It is now a class 1A recommendation in patients with type 2 diabetes plus chronic kidney disease to use SGLT2 inhibitors, DAPA or IMPA. They are recommended to reduce the risk of heart failure, hospitalization, or cardiovascular death. In addition to that, you could use finerenone in patients with type 2 diabetes and CKD. They are recommended to reduce the risk of heart failure hospitalization. So the SGLT2 inhibitors, CANA, IMPA, or DAPA, are recommended in patients with type 2 diabetes plus chronic kidney disease with an estimated GFR of more than or equal to 20 milliliter to reduce the risk of cardiovascular disease and kidney failure, and the maximum tolerated dose of an ACE inhibitor or ARB is recommended. Again, this is against the previous practice to stop ACE inhibitors or ARBs in patients with chronic kidney disease. It was always a problem to find some of our colleagues discontinuing ACE inhibitor or ARBs in patients with chronic kidney disease. Now, the maximum tolerated dose of an ACE inhibitor or ARB has a class 1A recommendation, as well as CANA, IMPA, or Dapagliflozin. Thank you very much.
Welcome. We'll skip the question.
بالنسبة للميكانيزم، خليني أحكي على موضوع الميكانيزم of using SGLT2 inhibitors. Actually, it was found that they reduce the use of glucose in the metabolism of the myocardium, and they started using the free fatty acids and amino acids in the metabolism. They reduce preload and afterload, and they improve diastolic function. Okay. This is the way how they work actually in patients with heart failure and preserved ejection fraction.
Thank you.
Now, one other thing, it was mentioned by my colleague here that it is now being used for hyponatremia. This is true. It is a new recommendation to use SGLT2 inhibitors in patients with hyponatremia because of the free water clearance. They clear water more than they clear sodium. So you reduce free water that is in the circulation, and at the same time you preserve sodium in the circulation.
Two questions. First question, Dr.
Thank you, Dr. Zaher, for this very informative presentation. We almost always are seeking for the update. It has been found recently that the role of beta blocker in patients with LV dysfunction and AF is weakened for unknown reason, probably because of the mechanism of action of the beta blocker and interference with the AF. The second new thing is the role of beta blocker is also not very clear in patients with renal failure. Those people with renal failure and they have LV dysfunction, also the role of beta blocker is not that good. The third thing, which is now recently raised, that the sacubitril in combination with valsartan may increase the incidence of dementia in patients with heart failure. Because sacubitril, we know it is anti-nitrolipsin. Nitrolipsin, the role of nitrolipsin degrades the beta amyloid protein. So the level of beta amyloid protein will be increased, and this will lead to dementia. Thank you very much.
بالنسبة لموضوع atrial fibrillation, بجوز أنت انتبهت بأنه regardless of the patient having atrial fibrillation or not having atrial fibrillation, the benefit was there. يعني irregard of being in atrial fibrillation or not in atrial fibrillation, the benefit in cardiovascular mortality and hospitalization for heart failure with Dapagliflozin was definitely there.
One rapid questions regarding IMPA and DAPA in the management of heart failure. Do you see any difference between the two arms in management of heart failure?
يعني this is a political question.
I will answer. There is no comparison trial. There is no comparison trial.
يعني اثنين إخوة يعني الحسن أخو الحسين.
But it is a group effect. I think they are the same.
Thank you, Dr. Zaher.
Allah يسلمك.
Now it's our pleasure to have Dr. Hadi Abu-Hantash. He is a well-known interventional cardiologist. He will speak about transforming atherosclerotic cardiovascular disease.
Thank you, Osama, for the kind introduction. And following Zaher, I'll try to be as concise as I can.
Cut it short. Cut it short.
Well, actually, I'm given 30 minutes, so I'll just take my time and hope I can share thoughts with you. Let me just first again congratulate the organizers for the meeting, and hopefully it will continue to be successful tomorrow. And thanks for inviting me, for sure. I'm invited by Novartis to give this lecture, so it goes without saying that I have a conflict of interest. As Zaher said, it's political, but there is a conflict of interest because I'm going to get an honorarium for what I'm telling you tonight. So I have to restrict myself to science, and I hope I can do that. Now, challenges for treating hyperlipidemia remain. We are in 24, we still have big challenges to go. Let me give you this scenario of one of my real patients. A 61-year-old lady, she has no diabetes, no hypertension. She is a non-smoker. Her mother had diagnosed coronary artery disease at age 65. She had 3 siblings who have hyperlipidemia. She's not overweight. She is on good dietary habits, very active, sports, gym, everything you can name it. And she had on and off atypical chest pains. A treadmill EKG, which a lot of my colleagues now is postulating is obsolete, but I don't think it is obsolete. It still has a lot of value in evaluating patients with chest pain. Showed mild, low-risk, positive, silent ischemic response. So I did the CTA coronaries. It showed normal coronaries, and to my wonderful surprise, her calcium score was 0. There was no calcium in the coronaries. But look at her initial lipid panel. Her total cholesterol is 420 milligram per deciliter, LDL 292, HDL 79, triglyceride 212. So what do you think this lady's target and goal? Let me just tell you something about the target and goal. I always say it, but I don't want to bore you with that. When you talk about lipid target, the target is to lower the absolute number 50% or more. That's a target. So that's what you target. But the goal is a number. So the goal is like below 100, below 70, below 130, below 55, below 40. That's the goal. So there's a difference between both. So what do you think? Where is the target for this lady? The target should be 50% and above. But what's the goal? Where should the LDL be for this lady? She's 61 active, so she might live another 30 years. She might develop coronary artery disease 10 years from now. Well, according to the European Society of Cardiology definitions of cardiovascular risk categories, she's actually a high risk. Why is that? She has a markedly elevated LDL cholesterol above 190. And on top of that, she has positive family history of coronary artery disease. But family history of premature coronary artery disease, allow me, Chairman, to define it more accurately than a lot of people do it, because it's important. How is it defined in guidelines? If you have an immediate first blood relative, أخوك, أختك, أمك, أبوك, خالك وعمك وستك, it doesn't matter. If you have one of those who has a documented premature atherosclerotic cardiovascular disease, when we say ASCVD, it can be stroke, carotid disease, renal artery stenosis, etc., whatever it is, peripheral disease, in addition to coronary disease. In females, below 65. In males, below 55. That's how it's defined. So if somebody's dad had a heart attack at 60, at least by data which we know, that's not a positive family history, by definition. Some guidelines refer to a mean value of 60 for both genders. So this lady actually, Her mom had coronary disease at age 65, so she missed that line. But she has familial hyperlipidemia. 3 of her siblings actually have hyperlipidemia. So she classifies as a high-risk patient for developing ASCVD. One of the things I like about the ASC guidelines 2019, this figure, I think it just tells you everything about hyperlipidemia. If you just dig into it, every part of it, putting the values of the LDL on the left perpendicular plane and the horizontal, the risk, low, moderate, high, very high, and risk in terms of cardiovascular risk. Where do you find this lady? You find her here. Family, history of familial hyperlipidemia without other major risk factors. If she were a smoker, diabetic, hypertensive, one of those, she would qualify here as a very high risk. So the goal of getting her to below 70 is what we're aiming for. 50% is not going to be enough. Her LDL is 292. 50% will be, 146. That's not enough. You still need another 50% on top of that. So I gave her maximum dose of a statin. She could not tolerate except 10 milligram. Added ezetimibe to that. On her follow-up, the lipid panel showed a total cholesterol of 306. It worked, but not to the goal or the target. The LDL remained at 203. So what would be our next step here? Use Rosova 40. Well, the rule of 6 still stands. 10, 10, 10, 6, 6, 6. So she's not going to get to the target. Double dose of ezetimibe. There's nothing called ezetimibe 20, by the way. I just put it as a tricky question here. There's only 10 milligram, and there's no 5 milligram even. That's a standard dose. Adding Repatha evolocumab as a PCSK9 inhibitor, not a bad idea at all. But she had to take about 42 injections a year. But you can postulate that, of course, or add something else. Where is the gap? The gap which we have in treatment lipids, we deceive ourselves. We say, well, in the WASCOP study, there was a 29% reduction of MACE, all right? 71% residual risk. That's what it means. 71% residual risk. We did not get 100%. Even in the Jupiter, as a primary prevention trial, it was 44%. 56% of the people are still at risk. So there is a big gap. We're not there yet. Now, despite of all the advances we have, I'm sorry if that's not showing very well, we managed over the years from 1990 down here to 2010 to decrease the incidence of mortality and cardiovascular death in patients. You look here at Austria, Canada, Germany, US, etc. But unfortunately, it's coming back up. I think it's our lifestyle is not really, probably that's part of it. And 24 million deaths per year are expected by 2030. فإذا أولادك حابين يصيروا cardiologists, tell them there's plenty of marketing for them in the future. A lot of patients to treat. The problem with getting one incident of ASCVD event is that it doubles the risk of MACE for those patients. إذا إجاك مريض عنده myocardial infarction, the problem with that, it's a cumulative risk after that. يعني عمره ما هذا المريض هيصير عنده 0% risk في حياته، إيش ما عملت له؟ أو اللي بيصيبه ischemic stroke is the same. Lowering LDL, the lower the better. It has been with us for the past, I guess, at least 15 years. And we all believe it. I hope everybody here in the audience believe that the lower the better. Now, you can postulate that I will start lowering the LDL at age 50 for the patients and try to get it down as much as I can. So the cumulative LDL exposure per year matched with the total plaque burden is decreased. However, if you go earlier in life and you do the same, you will get a big reduction in that. What does that mean? Treat them earlier, the better. Sustain the treatment longer, the better. And do not worry about how low the LDL is, because it does not cause major adverse effects. This is an old information, which everybody knows, that if every 1 millimole, which is 39 milligram per deciliter reduction in LDL, is associated with about 20% reduction in cardiovascular events. That includes major vascular events, mortality overall, and when you look at the all in all major vascular events is the same too. So lowering the LDL is of a great value, and we cannot ignore that. بس وين المشكلة? Why is the gap? Why do we still have a big residual risk? Look at this here. بال 2019 ASC European AtheroSclerotic guidelines, up to 80% of the patients did not reach the LDL. شو كاتبين هون؟ Target. يعني حتى the European Society of Cardiology, they're using the two words interchangeably. This is not goals. It should be goals, actually. It's not a target. But anyways, despite 90% of them on medium or high dose statin plus ezetimibe. What does that mean? That means that most of the patients, I would not say all, of course, they would not get to the goal, if we are being realistic, by giving them a combination of statin and ezetimibe. What is the problem with statins? كلكم بتعرفوا. The problem with the statins, there's a median of 15-month incidence of drop out of statin therapy, either because of side effects, because of not believing in it, or pocket, because of the money, which is كلياتنا بنشوف هذا الحكي. We all see a lot of our patients who stop taking statins. One of the myths which we were worried about, كلياتنا بنتذكر تعلمنا واحنا صغار بالميديكال سكول انه لما نولد ال LDL تبعنا is about 40 milligram per deciliter, right? And that we need the LDL for cholesterol metabolism, for the maintaining the blood-brain barrier, etc. Basic things تعلمنا من زمان. وكنا خايفين انه اي حدا بينزل عنده ال LDL below 40, maybe that's not good. Well, the studies which I think the major study which taught us about this is the Fourier trial, which came out several years ago, which used PCSK9 inhibition. When you look at all the side effects, look at this here. This is so little, but I guess you can see it. Down to a 19.3 milligram deciliter on the left side here. The major adverse effects were not different. يعني أنت مريضك نزل ال LDL تبعه ل 19 و 18. إذا إجاك المريض, especially if he is a very high risk ASCVD patient, مش لازم إنك تتضايق ولا لازم تضايق المريض. Continue on the same therapy. Nothing is going to happen in terms of side effect profile. So I started by saying I was invited by the inclisiran makers, Novartis. You all know about inclisiran, of course. It's a twice a year subcutaneous, every 6 months treatment on top of statin therapy and ezetimibe, whatever the patient should tolerate, if they are not reaching the goal of the LDL. How does it work? The small interference RNA is inclisiran. What does it do in a simple fashion? LDL in our liver, you need a lot of LDL receptors so that whatever is circulating in the LDL is taken out of the blood circulation, and that's how it works. Simply, it doesn't let the LDL precipitate inside the arteries in the intima and cause atherosclerosis. In a simple fashion, that's how it works. Now, it was approved actually for certain indications, and I think that's very important. In adults with the primary hypercholesterolemia, heterozygous familial and non-familial, or mixed dyslipidemia as an adjunct to diet, and in combination with a statin or statin with other lipid-lowering therapy in patients unable to reach LDL cholesterol goals, حطوها صح, goals, with the maximum tolerated dose of statin. يعني ما بصير انك انت تستعمل انكليسيران لمريض عماله باخذ اتورفاستاتين 10. Come on, it doesn't make sense. You have to push it to the maximum tolerated dose 40, 80, and accordingly, you add then ezetimibe. If they're not at the goal, then you start inclisiran. However, it can be used alone also with other lipid-lowering therapies in patients who are statin intolerant or for whom statin is contraindicated. We see يعني المريض اللي ما بيتحمل statin يعني كأنه ما بياخد statin. It's as simple as that. يعني he's naive to treatment. Now, it has been studied extensively in the Orion 9, 10, and 11 trials. It was studied in heterozygous familial hyperlipidemia. In the 10 trial, it was ASCVD patients. And in the 11, ASCVD and ASCVD risk equivalent patients. And followed those patients for 1.5 years. And what it showed consistent finding that whether it's Orion 9 in familial hyperlipidemia, Orion 10 in ASCVD patients, or Orion 11 ASCVD and ASCVD equivalent, that the LDL is lowered very quickly within 90 days maximum, and is sustained lowered at an average of 50% on top of the statin and on top of the ezetimibe, which is really wonderful. That's what we want. One thing important which really catches my eye, look at the Orion 9, 10, and 11. The people who reach below 70 as a target, about 74% of the patients. But below 50, 19% only in the hyperlipidemic patients with familial history of hyperlipidemia. It really caught my eye, actually, compared to 60%, 51% in the ASCVD patients. That tells you how much of an importance, like my patient, is to start them on inclisiran as soon as you can. Because even with the inclisiran, on top of statin, on top of ezetimibe, if they are having a goal, like my patient, if she has another major risk factor, you are having a big challenge in your hand. Following those patients up to 6.8 years, you lower the LDL, consistently stays the same. Wonderful, that's what we want. So you have a patient who had a very high risk for ASCVD, high dose statin as much as tolerated, plus ezetimibe, plus inclisiran, almost up to 7 years, consistent lowering of the LDL on follow-up. Now, this is a study which was presented at the ACC 2024, and thanks to the Novartis people, I have to admit I wasn't aware of it for whatever reason. They shared it with me and I looked it up. It's kind of interesting. It's called the Victorian Initiate Randomized Trial. They simply, in 45 sites in the United States, they simply said, well, let's see in the real practice, the patients who come in first and they are not at target, who have ASCVD at target. America, the target was still below 70. In Europe, it's below 55. You know that, right? So anyways, so if they are not at target with the maximum tolerated dose of statin plus ezetimibe, they start them immediately on inclisiran. The other arm is simply the usual work. If they are on rosuvastatin 20, you push it to 40. If not ezetimibe, you add ezetimibe. Or other new agents, and you follow up those patients. This is just the routine work. Now, the co-primary endpoints they had is they wanted to see what's the % change in LDL cholesterol from baseline up to almost 1 year. And the discontinuation of statin therapy defined as no statin use more than 30 days before the end of the study, which is good. In the real life, بدهم يشوفوا هالقصة هاي اللي بالأوريون, is it the same in the real life? Patients who were enrolled in the study, the demographic part, I think it's, you know, the age, the female representation of only 30%, it's just the usual everywhere in ASCVD trials. But to look at that, 93% they had ASCVD, and most of the ASCVD events occur below 1 year prior to the consent. And the history of statin intolerance was 59%. شكله اللي بنشوفه بحياتنا اليومية everywhere across the globe, Africa. the statin intolerance is a major problem. It's really a major problem. The LDL cholesterol upon entry was a mean value of 97. وإحنا قلنا by the definition of the United States, they wanted below 70. So how did adding inclisiran immediately if you are not at target compared to the usual method of managing patients of upping the statin, adding a new agent, etc. worked? Well, obviously, if you do inclisiran first, you get a lower reduction within 90 days up to 58% and sustained up to 1 year, which is wonderful. But look at if you do the usual care, it's hardly 7%. I'm sure you're not surprised by that. I'm not surprised, actually. But that tells us that what showed in the Orion study is actually the real of what we see in our day-to-day practice. The co-primary endpoint of statin discontinuation, look at this. Inclisiran, when you started immediately, if they are not at target, patients did not discontinue the statin, 6% only, compared to almost 17% when you start upping the dose or adding other agents. So it really adds up to the it's not only compliance and adherence of our patients. What is the key secondary endpoints in terms of individual LDL goal attainment over time? Let me push on this here if it works. My friend, there is a video hidden here. Can I see it? There is a video. Thank you very much. It has to play from you, huh? Anyways, it worked, okay? The patients, LEQVIO is the same as inclisiran. I always avoid when I stand in podiums to use trade names because I really don't like that at all. But I could not really get this out. But so LEQVIO, which is the same as inclisiran, of course, that's the trade name. Patients who got it actually from the start. If you look at a goal below 70, 81% really got to the goal. If you look at below 55, 71% got to the goal, compared to the usual care of only 22%, defining as the goal below 70, and only 8.9% if you define the goal below 55. So inclisiran does not only lower the LDL, it actually gets you to the goal more frequent. That's what we want. That's what's going to really narrow the gap for ASCVD patients in terms of future events which might kill our patients, unfortunately. The key secondary endpoints in changes according to the lipid-lowering therapy. What you see here is when you inclisiran the patients immediately first, compared to the usual work, what do you find? 88% patients on statin as only the background in the inclisiran, which surprised me for whatever reason. Combining therapy, which is here in the little thing here underneath, with ezetimibe is not common in practice, even in the States. I don't know why. I don't know how to explain that at all. Because the guidelines are very clear, even in the United States, in terms of cholesterol lowering in guidelines, you actually up your statin dose to the maximum, you add ezetimibe, if you do not at the goal, at the time when you use PCSK9, you add PCSK9, now we add inclisiran. So I'm really surprised. But the usual care patients, 73% on statin only at day 330. Again, less patients on statin and less patients on combined therapy. Safety, well, like the Orion study, it did not really matter. Whether you use inclisiran from the start or you use the usual care, major side effects are not there. The only side effect which is different, which makes sense, the site of the injection subcutaneously. Sometimes you get some induration, redness, etc., but nothing really major. So they concluded that the clinical value of initiating inclisiran early in the treatment pathway, highlighting the urgent need to improve usual care for US patients with ASCVD. So to lump sum it, I always say your best bet to lower the morbidity and mortality in your patients is from the first time you see them. We always argue back and forth of upgrading our treatment. Didn't we learn from the hypertensive treatment of our patients? We should learn from that. Your patients, when they come to you, if his blood pressure is 180 over 100, and you leave them with a single therapy that day in the office, do you think that they will come back with a good blood pressure after 2 weeks? Impossible. It's really impossible. You have to do it by guidelines, combine the therapy from the start, push the maximum dose from the start, and don't keep waiting. Talking about safety again, when they pooled Orion 10 and Orion 11, it's a safe medicine on top of statin plus minus ezetimibe. So don't worry about major side effects. إذا في حدا بخيل في الدنيا in terms of spending money هم ال NHS in England. Everybody knows that. اللي تربوا England, they know it. They don't like to spend money. However, look what the NICE said when inclisiran became available. Inclisiran is considered cost-effective in people who have previously had a cardiovascular event, the very high-risk patients, have persistently high LDL level above 2.6, which is 70, despite maximum lipid-lowering therapy. Therefore, inclisiran is recommended for reimbursement as an option in this population. يعني إذا أهل إنجلترا حكوا لك هيك على عادي معناته things are going well for inclisiran. The United States, the FDA approval label is very, very cut clear. It's indicated for adult patients with heterozygous familial hyperlipidemia or clinical atherosclerotic cardiovascular disease who require additional lowering of LDL cholesterol to the goal value which we're looking for. It's a very simple thing. الحقيقة اللي استعملوا منكم معظم المرضى they don't find it a very difficult thing. تعطي 300 ملغ اليوم 300 ملغ بعد 3 شهور وبعديها بصير كل 6 months 300 ملغ. Very simple. The only thing not simple about it, it costs a lot of money. So that's for you to ask the Novartis about it, not me, of course. It's a very expensive medicine, but it's a very cost-effective medicine at the same time. So what happened to my patient? I started her on inclisiran 300 milligram. Of course, I gave her the second dose. The lipid panel after the second dose. After the 3 months. Total cholesterol 180, LDL, oh, I'm sorry, it's I did not type it in here. The LDL was 106 or something like this. HDL 85, triglyceride of 100. And with a wonderful thing, liver functions are normal, CPK did not rise, no any additional side effects. And believe me, she's a happy camper. She's really very happy. She looks at her numbers and she's very happy. Somebody might say, well, you want it below 70, yeah, but we're coming close, my friend, but 106 is not a bad thing. So with this, let me finish, and thank you very much.
Any questions for Dr. Hadi?
Raed.
Thanks a lot for this bulk of information in 28 minutes. So that's really good. Thank you. So my question, I'm going to be the devil's advocate here. And I'm saying that statins, they don't act just through the LDL. They have non-LDL effect. Does inclisiran have any of those effects?
My friend Raed, pleiotropic effects of statin. Give me one randomized trial which really proved that it's there. It's a science, but it's not shown in randomized studies. Nothing showed us that the pleiotropic effect of statin is good, but it's wonderful. Jupiter study, the LDL was reduced for sure, but it's the LDL, the high sensitivity CRP. I'm following up on your question. And the high sensitivity CRP is what showed the benefit. كلمة pleiotropic effect, what does the pleiotropic means in Latin? يعني إنه إشي تاني غير اللي أنت متوقعه عم بصير. It's a good question. Would it have any other pleiotropic? I don't know. All what I can tell you, it's like the argument of lowering blood pressure. We went back and forth. بحب أنا حبيبي زاهر لما حكى سؤال بقول لك it's political between SGLT2 inhibitors. Allow me, Zaher, to tell you it's not political. They work the same. Why confuse the picture anyways? You know, they really work the same. They're wonderful molecules. أنا بقول دايما بدل ما إنه نضيع وقتنا on differences between molecules, خلينا نضيع وقتنا to convince people to use it. That's what we will have to do. Same thing for inclisiran. Blood pressure medications, you look at that, right? Hydrochlorothiazide is the cheapest medicine on earth. في شيء ما بعرف شو يعني يمكن حبة الفستق اللي أرخص شوي. But it works by lowering blood pressure. And when you look at the outcome of any hypertensive trial, where is the major benefit? If you get to the blood pressure goal. It's not how you get there, but getting there is very, very important. The same thing with the LDL. The lower the better. What we are learning since the lipid clinics were invented in the mid-80s, lower the LDL to the maximum you can, and as long as you don't have data that it's really, that molecule is bad, then probably it works. But if you have any data on pleiotropic effects, I would love to share it with you. I respect your...
شكرا جزيلا أستاذي الفاضل دكتور Hadi about this very nice presentation. We know that insulin is giving for patients who are not responding to full dose, maximum doses of statin, and also who are not tolerated the statin. The last 3 trials, not the Orneon now also it is going. They don't show the effect of this drug on the mortality, cardiovascular mortality. Why they not concentrate on this?
My friend, if you want to organize a randomized trial and get a total mortality reduction, I'm not a statistician, I hope somebody is in the audience here. It all depends. You have to know in that particular population of patients, what is the absolute risk of that cardiovascular event in that population, right? Then the statistician comes and calculate how many patients you have to enter in the study to show a total mortality over a period of time. Usually, it has to be more than 1 year. Usually, you need a humongous number of patients. If I recall from the days when I was a little kid, when I was a fellow, you're talking about 18,000, 16,000 patients. So this is not an easy encounter. This is part of the answer to your question. Now, one thing which I learned over the year, do you know which of the statins was the earliest to show a total mortality reduction? Anybody knows in the audience? Sorry? Simvastatin, right? The 4S trial. Thank you, Islam. The 4S trial is the one which showed us decrease in the total mortality. You go to the 4S trial, see how many, أنا مش متذكر كم مريض, but see how many patients were enrolled, how many they were followed up. بعدين بدك تتذكر شغلة بهالعصر اللي بنعيش فيه هلا. يعني أنت لما تيجي على مريض هلا كل الavailability of the new medicine عم باخدها المريض. أنت you are already dropping the relative risk already before you adding a new therapy. To show a difference, it's not an easy task anymore. It's not really. It's not like زمان لما كان المedications أسامة مش هالقد كلهم available أصلا. So I hope that answers your question.
Yes, maybe the ongoing trials may discover this.
We'll see how it works. Yes, sir. We have a question.
I'm going to be, my question is practical. We know the rejection rate for those prescriptions is 80%. 20% are approved. Out of 45,000 prescriptions written, 36,000 were denied. And the 20% that they were approved, there was almost no difference in the patient's characteristics between those who were approved and who were not approved. So we really have an issue here. I don't know how many prescriptions in Jordan, 11 million people. Some I heard like 14 prescriptions in a population of 11 million. So there is a big difference between the practical life and the science. If I have a good medicine that I am prohibited from using, I mean, it's useless at the end of the day, honestly. What's your take? Thank you.
When you say approved, you mean by the insurance companies or by the insurance companies? Yeah, This is really a very tough question, you know that. In general, let me be the devil advocate, زي Raed. Where is our way of treating our Jordanian individuals, our colleagues, patients, etc., in this country? Let me give you an example. We see medicine which makes a difference. It's a bit expensive when it starts. And then we start like what you said. What we're getting is rejection of our prescriptions from the insurance companies, from the public, what have you. What happens is, هاي الدكتورة نيرين عندي هلا دخلت من القاهرة. Nireen can tell you إنه inclisiran في مصر is doing a lot better than most of the Middle East. Am I correct, Doctora? Why do you think, can you give the microphone to Dr. Nireen, please? I would love to hear from her. عشان جاوبك السؤال. Why is inclisiran getting easier prescribed and filled in Cairo? Can you give her, please, the Dr. Nireen? She will give you the answer in a minute, my friend.
Not to that extent, but I believe in that because maybe we could convince the insurance companies that they can pay for the inclisiran, and it is going to make, it is much cheaper as a long-term management for our patients with hypercholesterolemia. Especially those who are resistant to the high-intensity statins, they're not getting there. We have some patients that we go for intervention once and twice and 3 times and maybe 4 times for intervention because they didn't reach their target for the LDL, or we can't get them to the target for the LDL. We could convince the private insurance companies as a start. They started at the beginning, and then now the governmental insurance is supporting the inclisiran with some of the NGOs in Egypt. So that's why we are starting to prescribe it more and more.
Thank you, Nireen. Any more questions? I'll be happy to answer.
Thank you, Dr. Hadi.
Thank you, Sam.
For the nice lecture.
Thank you.
Okay. Thank you, Dr. Hadi. We will move now for Dr. Islam Abu Sido, my colleague and my friend. He's a senior consultant cardiology. He will talk about systemic review of hypertensive management guidelines. Dr. Islam, the floor is yours.
Shukran, Dr. Jabri. Thanks for panelists. Thanks for Mr. Chairman inviting me. Shukran. Thanks for Omnitrade inviting me. بعرفش قديش معطيني time. 15 minutes? Okay. 15 so I'll do my best يعني بصراحة. Okay. So I'll go over quickly the latest updated guidelines from European Society of Hypertension 2023. I hope that's not going to be boring. So as everybody knows that hypertension is truly a burden throughout the world. And the problem is the high prevalence that's expected that to face the 1.4 billion adults to be hypertensive in 2019. And unfortunately, the prevalence increase pretty much like in our countries, low middle income countries. And the problem, the sequelae of this hypertension is the death mortality. So 10.8 million people will die out of those population from high blood pressure. And what kills is truly out of this hypertension is heart disease, stroke, and heart failure. Apparently, the estimated cost is globally, it's really costing a lot of money. Hypertensive management causes almost like $100 billion per year. Now, where are we compared to other countries in the region? In Jordan, this is from WHO 2017. Jordanians, almost a quarter of the population are hypertensive. But when you look to our neighbor countries like Qatar, Oman, Gulf area, pretty much higher prevalence. Now, the problem with hypertension is truly difficult because you need to control not only the high blood pressure, you need to control the comorbidities. ما بيجي straightforward hypertensive patient without other comorbidities. 57% of those patients with high blood pressure, they have dyslipidemia. Almost 50% they are obese, and almost 55% they have diabetes. So controlling hypertension apparently is the most important, but we need to control other morbidities with this high blood pressure. Now the problem also that this blood pressure remains across the region poorly controlled. Look at Kuwaiti population, Saudi population, we're lagging behind. So controlling rates are really low compared to the rest of the world. And as we just mentioned, that high blood pressure is truly the leading cause of death worldwide compared to other medical illnesses. As I just mentioned, 10.4 million deaths every year. Now again, 2 out of 3 treated patients actually have uncontrolled hypertension. So we are happy that we are treating, but still the problem, these are the unmet needs, the gaps actually. From the pure trial, you can appreciate that almost a third of the patients are actually controlled and 2/3 they are not. And the problem, not treating those patients or not controlling the blood pressure is the dramatic sequelae, the consequences. So cardiovascular mortality for those untreated, pretty much like those treated but uncontrolled. يعني نكون فرحانين والله أعطيته حبة دواء لكن هو بصراحة uncontrolled, pretty much the outcome is like those who did not get the pill. So for cardiovascular disease, heart disease, cerebrovascular disease, pretty much a poor outcome. And the other problem that we're facing is the poor control of 24 hours. So you need to know what medication that you're giving to your patient. You need proper 24-hour controlling of the blood pressure in order to lower the cardiovascular mortality. This is from a cohort that published in the New England Journal of Medicine to show that fatality and non-fatal cardiovascular events are really high, whether you're talking about systolic or diastolic blood pressure. And again, for fatal and non-fatal MI and stroke is significant actually for those patients who are poorly controlled. We learned a lot from the sprint. No matter what they criticize the sprint, but I like it actually because it showed us that those who were intensified in the blood pressure control, they got a dramatic reduction of cardiovascular mortality and morbidity. And you notice that the diversion of the curve was really little bit earlier to show that the primary outcome was in favor of those who are tightly controlled blood pressure. And the death from any cause is pretty much the same. So reduction in relative risk with intensive treatment was in favor of intensive group, 25% reduction of the primary outcome, 27% reduction of the death from any cause, and 43% reduction from death of any cardiovascular death. I'd like to remind you that when we talk about hypertension, it's really a modifiable risk factor. يعني ما حدا يقول إنه قدري أنا عندي ضغط. It is a modifiable risk factor. It's like smoking, it's like using alcohol, it's like unhealthy diet. So you can modify this blood pressure and you can control the outcome. When we talk about the latest European Society Hypertension Guidelines that was published in December 2023, I like to stress on certain points that is really important. Everybody knows that the normal blood pressure is or the optimal is 120/80. But we like always to tackle the problem for those patients who had a high normal blood pressure. والتعريف is 130, systolic to 139, diastolic is 80 to 84. And the reason for that, because those who had comorbidities ما بصير نعاملهم زي إنسان who had only high blood pressure. واحد عنده high blood pressure, okay, we're dealing with him, ما عنده any other comorbidities, 140/90, you treat him, you got better outcome. لكن هدول اللي عندهم comorbidities, عنده previous stroke, had coronary artery disease, had open heart surgery in the past, هدول they lower the threshold actually. We should not accept 140/90. So the guidelines gave them a class 1 indication to treat them, in particular for those who had a history of cardiovascular disease, predominantly coronary artery disease. You need to initiate a treatment if the systolic blood pressure more than 130 and the diastolic blood pressure more than 180. And by that you are quite sure that you decrease the comorbidities and risk reduction actually. This is the schema that I like regarding the newest guidelines. The newest guidelines make it easy for all of us, and these are based on evidence apparently. So when you treat patients, You need to start dual combination therapy in most of the patients اللي حكاه الدكتور هادي قبل شوي. And the preferred is to use a single pill combination rather than the conventional traditional method. متى احنا بنستخدم single pill زي ما حكى الدكتور؟ You should not يعني start single pill واحد blood pressure 180 over 100. You start a monotherapy in selected group of patients. والguidelines are clear. واحد عنده low risk hypertension يعني he's not diabetic, has no coronary artery disease, has no comorbidities. If the systolic blood pressure your target 150 and diastolic 95, then you're going to use a single pill. لكن otherwise you should not consider actually except dual combination. واحد فريل elderly عمره 85 هدول الناس اللي they were criticized في السبرنت trial. واحد فريل underweight advanced age you can start single monotherapy. تمام. Those who had high normal blood pressure just I stressed on them, and those who had high cardiovascular risk هدول we can start monotherapy in order. طب ليش عم نحكي؟ لأنه systolic is 130 and diastolic is 80 and above. So you lower your threshold, you use monotherapy. But for the rest of the groups, most of your patients, you should start dual combination in order to achieve your target. The guidelines are clear. ACE or ARB plus CCP or thiazide-like diuretic. Increase to the full dose that the patient tolerates. It's extremely important to quote the maximum dose that your patient can tolerate. And with this, you reach your target. 60% of your population that you are treating, you reach your target. The rest of the groups, you can use the triple therapy. I did not reach my target with dual, maximized, patient is tolerating, still the patient is poorly controlled. انت عارف إنه هدول they don't form more than 30%. So you use another pill, يعني بتعطي triple therapy. And then if he is truly resistant, then you proceed with your protocol to rule out what is the reason for resistant hypertension, and you choose the protocol that you use, whatever you need to add further. You have a bunch of medicine that you need. ونذكر بعض إنه again اليوروبيانز still عم بيحكوا عن البيتا بلوكرز وهذا which we respect, and I can tell you في coming guidelines from American Heart Association أو ACC, I can tell you beta blocker they're going to come back. ليش؟ لأنه في عنا a lot of evidence. So beta blocker can be used as monotherapy at any step or with combination therapy بكل اللي حكينا فيهم. ليش؟ لأنه there is an indication, there is actually an evidence to show the unique actually effect of those beta blockers. So this is a general blood pressure lowering strategy for general population with hypertension. بدي أذكركم هدول الcombination patterns اللي هم إحنا بنعرفهم وعارفينهم long ago, and there is an additional other classes that we can use actually in order to target our blood pressure. Remember to use earlier the single pill combination. With that you reduce the time to blood pressure control. وأنت كل ما بتقلل time to blood pressure control you get better outcome compared للفري combination اللي هم الconventional method حبة الصبح حبة المساء حبة آخر النهار. This is useless actually حتى على compliance والoutcome. Apparently using single pill combination to improve adherence and persistence apparently got actually from the guidelines a class 1 indication. So in the International Society of Hypertension قالوا لنا إنه the best actually or the ideal drug that we need that evidence-based, that reduces mortality and morbidity, that once daily regimen provided 24-hour blood pressure control, affordable, all these actually, that forms the suitable or the most ideal medication to control the blood pressure. آخر شيء أذكركم إياه في الجايدلاينز اللي هي published lately إنه التارجتس اللي أنا وياكم لازم ندور عليهم systolic 120 to 140, diastolic is 70 to 80 based on the evidence, and I like that actually. Now بدنا نحكي شوي عن مضيفنا اللي هو الكاندي سارتان اللي هو الاتاكاند. I'm quite sure هذا الدواء قديم جديد من الأدوية اللي إحنا I'm quite sure يعني we have all the evidence to support using such molecule. نذكر بعض إنه number of 81 receptor binding sites for different ARBs. نذكر إنه الكاندي سارتان has 4 sites for this binding. وهذا ورجة actually إنه outcome based on these bindings ability actually إنه أعطانا more strength compared to other comparators like olmesartan, telmisartan, valsartan, and so forth. And with that, actually, you maintain the inhibition of angiotensin II receptor with candesartan despite the fall of plasma level, so you achieve better control. Remember, in this cohort, actually, candesartan improved compared to valsartan, irbesartan, and losartan with this meta-analysis to show that highly effective blood pressure reduction as monotherapy compared to the comparators in this cohort. The relationship between the dose of antihypertensive effect and the 4 actually angiotensin II receptor blocker differences in potency and efficacy, this is just to show the effectiveness of Atacand or candesartan compared to the comparators اللي هم irbesartan, valsartan, and losartan in this cohort. The chance trial كانت على 3000 مريض 3000 patients who had mild to moderate hypertension وكان systolic 140 and above, diastolic more than 90 and above. Just show you the normalization with actually candesartan was way better than the comparator, and you achieve actually a good blood pressure control having candesartan 16 milligrams on board. القضية اللي بتهمنا كتير احنا in particular بنضلنا نحكي عن morning surge of the blood pressure. Epidemiological evidence reveals that the highest number of cardiovascular events actually occurs في ال early morning period. وعشان هيك بدنا good molecule actually to cover موضوع ال early morning. بدناش بتعرف هدول الديبرز والنون ديبرز extremely important إنه early morning إنه to cover those patients correctly. So you need a good medicine, and it has been proven actually given Atacand compared للothers للبلاسيبو اللي كانوا في in this cohort. واهم شيء نذكر بعض انه know your medicine. بدك تعرف الدواء اللي بنكتبه ونذكر بعض trough to peak ratio. If you achieve a trough to peak ratio consistency, you know that you protect your patient properly and you know that you cover him during the night time. This proves actually even if you miss a dose with this trough to peak ratio compared to the losartan, you're doing very well compared actually to the losartan, effectively controlling the blood pressure for 24 hours. We got the evidence actually كمان من هدول واحنا عارفين الهيستوري القديم انه الايس والاربس هدول كانوا كتير مهمين. They shine up actually to lower new onset of diabetes. عرفنا انه one of the best compared to the thiazide, calcium channel blockers, other molecules, ACE and ARBs are unique to lower the new onset of diabetes. And the evidence of candesartan من الAlpine trial, من الCharm trial and SCOPE trial that it is very effective to lower the incidence of new onset diabetes. Pretty much على heart failure كلنا حافظين الCharm trial كانت consistent, كانت على عدد كبير من المرضى 4,500 patients, and عرفنا انه with low ejection fraction less than 40% في الCharm trial we got achieved actually reduction of cardiovascular mortality, hospitalization and systematic. في البونر ترايل ورجينا overall we are doing good job having a reduction of systolic and diastolic blood pressure. Those who got Atacand actually or candesartan, they achieve or they were responders by 90% على كل levels, whether young, elderly population, obese patients, men or women, candesartan did very well. For the sake of time, just quickly about the sustainability of the blood pressure up to 48 hours, Carlos trial has proven that, and the Chile trial actually proven that the combination candesartan and thiazide is unique in type 2 diabetes and microalbuminuria. It improves pretty much metabolic actually parameters, and with that I like to conclude that we got a great protection having candesartan or candesartan اللي هو الأتاكاند plus highly effective in blood pressure reduction. Sustainability, you got it actually well tolerated based on the evidence, and it is extensively actually studied. With that I conclude. Thanks for the audience. يعني ضلوا أعانا آخر الوقت. Thanks for your attention.
Thank you, Dr. Islam Sidi. Thank you very much. Question?
شكرا جزيلا أستاذنا الدكتور إسلام على هاي المحاضرة القيمة. الحقيقة الهايبرتنشن is a very big medical problem. Nowadays, according to the new definition of hypertension, around 50% of the mankind are suffering from hypertension because of the new definition of it. Actually, not only in our region, also worldwide, there are 10 myths الخرافات العشرة اللي موجودة يعني بكل العالم. أنا ركزت عليها حتى كتبتها regarding the hypertension. ليش 10? Why it is not 9? I think because of the marketing. العشرة لواعل، أحسن 10 لواعيب، أحسن 10 مطربين، مو صحيح؟ فالحقيقة الخرافة الأولى تشمل إنه الديفينيشن، يعني الناس تعتبر هاي blood pressure is over 140 over 90 بينما هو يعني النورمال هو less than 120 over 80. الخرافة الثانية the sign of high blood pressure are obvious. They said if I am hypertensive I will be symptomatic. Some people believe that. This is أيضا خرافة. خرافة أخرى تقول as long as I don't add too much salt this is very good. I will not take a drug. الخرافة الرابعة تقول drinking coffee can raise blood pressure. ما لها علاقة. الخرافة الخامسة high blood pressure is more common in men. This is wrong. Men and women, especially after 50 years, يعني after the age of 50. الخرافة السادسة I don't need to take to make exercise and something like this because I am taking drugs. No, you are taking drugs, you have to do exercise. خرافة أخرى تقول blood pressure not prevented if it runs in families. أبويا أمي عندها ضغط ليش يعني هو ما هكذا. وخرافة أخرى تقول إنه if blood pressure is decreased so it become normal I will stop medication. وخرافة أخرى مهمة جدا وهي يعتمدون على الليمون اللوم الحامض نعمل دوزي أو الليمون الحامض. كل الهايبرتنشن ياخذون ليمون ينزل ما ياخذ بلاد بريشر. شكرا جزيلا.
يعني I love these things بصراحة. هو هذا البراكتس تبعنا unfortunately يعني 10 مثل اللي حكاهم actually احنا we are facing this on daily practice. I think we can يعني بصراحة talk about them till tomorrow. We can take each myth and discuss it thoroughly until tomorrow. So هدول this is reality what we face in practice. Thank you for your input. دكتور أيمن.
We all get an F. I mean 54% of the people with hypertension are diagnosed, 42% are treated, and 21% are up to goal.
Absolutely.
So we are responsible for 80% of the 50% who are diagnosed. I think we should spread more. This is probably a primary care issue. Awareness. Because when the patient comes to you, you see him in the emergency room with a stroke or a heart attack. I think we need to spread awareness. Treating hypertension is not giving the patient a pill. It's a lifestyle modification. It's what he eats. It's his weight. It's his exercise. It's the salt that he takes. It's not just take the pill and go home. We need to spend more time and educate our patients that this is multifactorial. And like you mentioned in this lecture, it has a lot of consequences that are more expensive to deal with than just trying to treat hypertension from the get-go.
Totally agree. Thank you, Dr. Ayman. Great. Dr. Raed. Oh, أنا آسف. أنت المدير.
That's okay.
أنا آسف.
Okay. Thank you, Islam. يعني just to be a little bit sarcastic, do you have an idea if blood pressure is more common in married or single men?
That's a wonderful thing. شوف أنا بقول نقطة الدكتور رائد بقول الهاي بلاد بريشر is poorly controlled في المرض or single. يا جماعة
depend on the wife. Depend on the wife.
سؤال خطير.
السؤال it's $1 million question. بصراحة بدي لكم إياها. أنا بالنسبة لي this is كاتيكولامين. اللي كاتيكولامين تبعه كويت ونازل هذا اللي he survive and he does not have high blood pressure. كاتيكولامين عالي سواء مرض or single أكل هوا.
حسب المرأة يا دكتور إسلام.
Thank you very much, Dr. Islam.
Thank you.
Now we finished our session. Next session is the complication session that we're all waiting for.